Okay, so anyway, we're going to get started without slides, and then we'll just see how it goes. For those of you that have the app, our slides were posted on it. We made a couple changes, but if you have the app, you could open it up, and pretty much we're going to follow along. We didn't really add much. We deleted a couple, so you should be able to follow along and do that while we're waiting. So this is Kristin Rising. Kristin, why are you here talking to these fine people?
I'm here because Judd made me. No. I'm here because I've had a lot of experience at this point with manuscript writing, manuscript rejection, revision, ultimate submission. Also currently I'm working as an assistant editor for Annals of Emergency Medicine. So here to give you my perspective, kind of what that's been along the way for me learning this process.
So, and I'm Judd Hollander. I've been here. The reason why I'm here is I was a deputy editor for the Annals. I was an associate editor for Academic Emergency Medicine, and I've published a ton of papers and everything, including the ER literature and general medical literature like New England Journal and JAMA once. And to give you the perspective. And we really have worked for a number of years on developing a system. I saw the look on your faces when I said, we'll teach you and you'll have your paper written in 20 minutes. We really have a system where you pretty much can sketch out your paper and do most of the intellectual components of it in 20 minutes. And we're hopeful that we'll get this up and we could walk you through that. But we'll begin with, authorship discussions, because when you begin to think about a paper, the most important thing is authorship. So show of hands, and mostly Kristin's going to do most of the talking, and I'm just going to be the color commentator and interrupt, but we haven't hit the point where I'm letting her talk yet. But show of hands, who has ever, before they wrote or before they started the study, figured out who's going to be an author and what each person's going to do? Raise your hands if you've done that. Who has had an authorship controversy where somebody wanted to be an author that you didn't think deserved to be an author? Okay? And was that before you started pre-specifying who's authors, or was that after? Both. Okay. So, Kristin, discuss your philosophies on authorship and how to avoid controversy.
Right. So avoiding controversy or minimizing controversy, I think, is really starting to talk about the process and figure out what your plan's going to be at project initiation or early on, right? So what are we doing this project? Like, ideally, you think about what publications do we know are going to come out of this work. You always have some other unexpected things, which are maybe some interesting side papers, but you always know what some initial papers are going to be. And at that point, it's really the best to think, okay, what is the logical distribution of this going to be? Are there different people who are going to lead different components of this? Who's going to be first and last author? Who's going to be on this paper at all? Who's contributing in meaningful ways? It leads to the best transparency and kind of satisfaction, I think, of team members. It also leads to writing your papers in a timely fashion, right? How many people have gotten to the end of the project, especially, right, you had funding, you were funded, you did your whole work, the funding ended, and like 6 months, 8 months later, you're like, oh my God, we never wrote our papers, right? And then like all momentum is lost. Nobody's really taking ownership for it. And so having that plan early and starting your papers, your background, your things you might even be putting in your discussion, the methods, right? Writing the methods while you're planning the project so you realize holes in your methods happens when people take ownership. And so having that discussion early is very valuable.
So I will also say that the thing that doesn't go over well, because most of you don't do it, is I actually, when I'm working with a mentee, require they write the whole paper before they start the project. Because who's had the experience where you work with someone and then they never closed out the deal? Yeah, a bunch of you have, right? So the way I avoid that is if I'm working with someone who's junior or a resident or somebody like that, is I don't work with them till the paper's written. Then it's easy. Then when the project's done, I can just put the data in if they just can't be bothered doing it. And it's not that hard, because what does your IRB proposal require? An introduction, the methods, the data sheet, which is effectively the results, and presumably you chose a study that there was a reason that somebody would care about, and that's the discussion. So it's not that hard. The intro is written, the methods are written, just write, and put in XXX or YYY or whatever fake numbers for your method, for your results. And the beauty of doing that is all of a sudden you find something you want to say in your results and oops, it's not on your data collection sheet. but you haven't started the study yet, so you can add it. And then write or at least list all of your limitations, because it's really hard to change a limitation. You could spin a limitation afterwards, but you can't change it. But if you can identify all your limitations up front, you can determine, I could fix this one or I can't fix this one. And then if you can fix it, you make your study better. And if you can't fix it, you know what your problems are going to be at the end of the day. So that's sort of our upfront discussion. So, Kristin, can you see slides? So,
I can see slides.
Okay.
Okay, so yeah, and the other point on authorship, right, is that there are standard guidelines. And so refer to these, right, and say, you know, is this meeting the guidelines conception, right? You were involved to study conception, design, conduct, analysis, or preparation of the paper. No one's done any part of that, and they're like, hi, I'm your boss, I'm the chair, I'm the something, like, too bad, right? You aren't contributing in a way that actually meets standard guidelines for this. Be clear from the beginning, as we talked about, and never leave out someone who did more work than someone you're including on the paper, right? And so if people have tangibly contributed, make sure that you are actually giving them the acknowledgement. So what we're going to work with here is what we call like the kind of 20-minute paper concept, right? And so we've asked that you break into groups 2 to 4 people-ish so that you can kind of make this a working session. People have found that super helpful in the past, I think, and kind of just engages the concept we're talking about a little bit. We'll walk you through doing an introduction and taking really like 1 minute to pick a topic, 3 minutes to work together to just sketch out like bare outlines of what an intro would be. You can make the topic as silly or as real as you want.
You got slides.
Wow, we have slides. Look at that. Great. We'll skip most of the methods. It clearly takes a little bit more time to walk those through, but kind of think about then when you're structuring results, what is that? So a couple minutes to make an example table one you might do, a minute for what main results you might be talking about, and then a couple more minutes to drill down into those. So first thing, before you write your paper, you design your project, you need to be defining a problem, right? Sometimes people just say like, I want to write about, you know, this thing, ultrasound of, you know, abscesses. And you're like, okay, what about it, right? What is the problem here? And so this involves a literature review, and defining some sort of unmet need or unanswered question. And then you want to design a study that can actually address the problem you've addressed, the problem you've identified. And you want this to balance out, right? You want to do the best study, design the best study that you could possibly do while still being realistic. What can I do in the real world setting with the resources that I have, right? It's all about this project design. So excellent writing cannot rescue a poorly designed project. Bad methods is bad methods. But bad writing can kill an excellent project. Papers get rejected when the writing cannot adequately portray what was done.
So let me comment on that and stress that, because if you're not writing the way we said, your paper before you submit it, you're not going to find the things that are wrong with it. And sometimes people do projects that at the end of the day, you're so in the weeds, it seems so important, but when you start to write it, it's kind of like a duh. And you don't realize that till you start trying to sell it. So whether it's an abstract, whether it's a paper, whether it's a program in your hospital, no matter what it is, think Shark Tank. Who watches Shark Tank on TV? Not too many of you. Shark Tank it's about grant writing for business. It's can you go in there and can you do a 30-second pitch that tells people what problem are you trying to solve? And coincidentally, Kristin Rising...
Judd's not hidden plug for Shark Tank here at 2:30, I guess, shortly after this, where we'll be doing this with a kind of series of seasoned investigators and some early-stage investigators to kind of rapidly go through and dissect some proposals. So,
But honestly, if you're in academics and you don't watch Shark Tank, it's on 24/7 on some of the cable channels. You honestly should go watch 2 or 3 shows, because they size up a project, these smart business people, in 30 seconds. That's what an editor does to your paper. They read the abstract and they determine 2 things. Is the project well done? If it's not, probably rejected. And is the project important? Does it solve a need? So I like to say this, you get published 2 ways, and I'm going to give you a real story. You get published because it's just cool, or you get published because it's really well done and maybe not as cool, but it's still useful and important. And so maybe one of you guys wrote it. There's a case report that I handled when I was at the Annals, which was someone came into the ER, and case reports are like not a big thing that the Annals strives for. Someone came into the ER in AFib, and they were, I forget what drugs or they were on, they were sort of acting psychotic, and the cop took out the taser and tased them, and they converted to sinus rhythm. Like, that's just cool. It's meaningless, because we're not going to recommend tasers for AFib, but it's cool. And so I was a deputy editor, and I literally wrote, guy in AFib, tased in the ER, on the monitor, converts to sinus rhythm. Publish, don't publish. Within 30 seconds, all 4 deputy editors and Callahan said, publish. And the paper was accepted. Like, because that's just cool. So it gets in. It's a case report, which is about cool, but decisions are made on the first glance. So if you can't sell your project fast, it's not going to go anywhere. No one cares about reading to page 14 to understand why it may or may not be important. Yeah, we covered this.
Yeah, we mostly covered this. We covered this. Yep. Okay, so the introduction. The introduction in its bare bones, and again, like most papers, really, 3 paragraphs is going to be enough, the bare bones. First paragraph, you want to be thinking, why should anybody care about this, right? What is the unmet need? We'll go into each of these in a little more detail. The second one is then the current state of affairs, right? And so this is that literature search you did. You kind of, in brief, give that summary to say, where are we at now? And kind of like, bring us up to that gap, that need that you're going to fill. And then the third paragraph is going to be the unmet need you are solving, right? Or the goal of this paper, right? And so paragraph 1, why should anyone care? There's generally 2 things that you want to be going for. Either lots of people have this problem, right? So it's a common thing we face every day in our department, or it's a rare event, but really bad things happen when it happens. And so generally thinking in those buckets will get to most of the why anyone would care. The second one, the current state of affairs, as I said, it's what we already know. So a literature review, summarizing it, right? This is not like list out each individual study and go into detail, but it might be a summary sentence that cites, 4 studies and another one that cites another 3 studies. And identifying in there where are the holes in knowledge that are relevant to the gap you're going to fill. And then the third paragraph, the unmet need, this should be a good, succinct framing of the study question. The type of study that you're going to do, your main outcome, and naming any discrete objective or hypothesis of your work. And so we'll take you back to those 3 now. We want you to work in your groups.
So pick a topic.
Us, go through this. I promise it's more exciting if you do it. So in your little teams, make up some problem you're going to look at, right? Some unmet need. And sketch out in outline format what your introduction might be for that.
It's really best if it's something one of you is interested in working on, because you'll really have the intro done in a short period of time. So take 2 minutes, pick a topic, and you don't have to write every sentence, but we are going to ask 1 or 2 groups to sort of read back and encapsulate what they would say about it. We salvaged it okay, I think.
It's all right. People can yell.
Where are you from?
Okay, 30 seconds. All right, guys. So let's cut a break now. So before we pick on a group to volunteer, or be voluntold, depending on how many volunteers, one of the things that I think would be useful is to you guys to reflect and sort of show of hands from, have a speaking person for each group or one person from each group. Did you more or less get it done in that time frame? Raise your hand if you more or less got it done in that time frame, each group. Okay, hands down. Raise your hand if you didn't get it done in that time frame. There's nothing to be embarrassed about. That's fine. So, about 80 or 90% of you got it done in that time frame. That's your introduction in under 2 minutes, sketched out. So let me have a group that wants to volunteer to tell us what their topic is and in 2 minutes summarize the 3 paragraphs. Who wants to volunteer? Okay, up front.
Well, we chose OUD, and our question is backgrounds.
So just go ahead and say it anyway.
So we chose opioid use disorder, and the background is fairly obvious, right? We've got a huge opiate use disorder issue in America, and there's as everybody in the room knows, there's a movement amongst emergency medicine providers, systems, public health, to initiate medication-assisted treatment, push it closer to the event, so people come to the emergency department overdosed, or we identify them as OUD. And so we're writing all these prescriptions for Suboxone. So our question was, does any of this have any effect on outcome? So does treating patients with Suboxone from the emergency disorder department reduce mortality in a period of time, say a year?
Okay, so I heard paragraph 1 and I heard paragraph 3. What I didn't hear is paragraph 2, which is what's the current status of the research on this?
Nothing.
Okay, so it would be important to say that, but somewhere in there, because you're solving an unmet need. So that's great, that's easy. And you guys had a hand up over there. You want to do your thing too?
Hello. So our project is, what we're working on is using ultrasound to diagnose dislocated shoulders. And why does anybody care about this? Because you encompass anybody in the emergency department who comes in. Their standard is to just get x-rays, and like anything else, it's a longer time they're suffering. And so using ultrasound has shown to have high sensitivity and specificity. And if you look at it, there's meta-analysis that shows that there is, which is the current state of affairs. What's unmet about this is no one's looked at this as they're always like individualized by institution, and what we wind up doing is actually a prospective trial at 2 institutions. So this is a multi-center study looking at a suburban population and an urban population.
And what's your outcome?
The outcome is to, again, look at the sensitivity and specificity. And if you look at the current state, people have looked at different approaches, whether it's from a posterior or lateral approach. We used only the posterior approach, and we were trying to look at how long it takes a person to come up with the diagnosis, as well as what their confidence is, and the time between the ultrasound and x-ray. Okay,
so I think that's really important, because I think what you said at the end is different than where you started at the beginning. Because, and this is just coming from my perspective as an editor and dealing with 8 million ultrasound papers over the years. I don't really care about the sensitivity and specificity, because we don't have a problem with diagnosing dislocated shoulders. However, we do know that the more rapidly you put them back in, the easier they are to put back in. So getting to the time to diagnosis then might have an impact on treatment, and you're getting there. So you can sell it, and you need to sell that stuff up front. One more group. In the back, Dimitri. Thanks for volunteering. Okay.
So the idea is is looking at the use of ketamine in treating status epilepticus. So the background is that status epilepticus happens. People get snowed by appropriately with multiple doses of benzos and move on to an AED, and then either they're still in status or they're obtunded or they need to be intubated because of the amount of drugs we give. So why not see about putting ketamine further in frontline rather than using it for refractory status as a bolus dose?
Okay. Anybody want to add anything to that now that you're all experienced? Or is that perfect?
Can't be perfect.
I'm kind of okay with it too.
Okay.
That's fine. Just, I want to be interactive and do this. So let me give you one of the examples why this is a great approach. Because, go to the next slide. So this is what I actually do in writing my papers. Like at some point, for half an hour between meetings, I sit down and I'm like, okay, what's my introduction? Paragraph 1 is paragraph 1. Paragraph 2 is, more or less what I know off the top of my head or my lit review. Paragraph 3 is what I did. So this is a real paper that I've not yet submitted for publication, which is kind of sad because I made these slides 2 years ago. But this is a telemedicine project describing our direct-to-consumer telemedicine space. So the first is healthcare is changing. Customers prioritize convenience and one-stop shopping. We know that, lots of literature. Second paragraph is there's growth in urgent care and retail and a decrease, and emergency medicine too for that matter, and there's a decrease in the amount of primary care visits, which means patients really kind of want one-stop shopping. So we developed the telemedicine program, and our objective is to describe our initial experience creating a direct-to-consumer telemedicine program. Right? Now, that's one thing. Go to the next thing. This is my next flight when I had nothing to do for a little bit. I'm able to write out those next 2 paragraphs. It means I don't have to sit and block out 4 hours of time to write my paper. I just need to write a paragraph in my paper anytime I feel like writing a paragraph in my paper. And that lets me be a lot more efficient with how I do it if I know what I'm going to say. And sometimes I write my intro first, and sometimes I write my limitations first. Depends where my head is in the project, and I can sit and do it.
So moving on to the methods. Anyone have any burning questions about the introduction? Well, if we have time for questions at the end, we can talk in general. But so methods. You want to provide enough detail for the reader to reproduce the study, right? Don't handicap your reviewers and leave out key details. Tell the journal really what they need to know to decide if this was an adequately designed study. They can always tell you to remove things. They don't know things you don't tell them, right? And you don't want to make them guess about what you did. They might be guessing the wrong way. And this is really, you win or lose here. If we don't trust the methods of your study, we don't trust the results, we don't trust the paper, right? And so the methods are really important.
So I, on this, and I'll take, it could be multiple examples, but I'll take a New England Journal paper that I had published there. They only give you 2,700 words. You can't describe what you did in 2,700 words. So I submitted the paper with 4,000 words, and it ended up getting published there, and they wrote, you got way too many words, we removed 1,300. So I just took out almost all of my methods. But they had everything they needed to review it and know it was a high-quality study. And then I was able to reduce what was a paragraph to a sentence and refer to clinicaltrials.org where the whole protocol was. But if I just did that, the reviewer is probably not going to clinicaltrials.org to look at the paper. So I give them all the information they could possibly want to decide. They decided it's good. Now that could go away. I don't need the same level of statistical detail. I don't need the same level of enrollment detail.
So wouldn't that get stopped early in the process by initial screening processes and sort of say, come back to us and revise this, get the word count, and then we'll fund this?
So it really depends on the particular journal. I mean, we had, after that first round, they said resubmit it with 2,700 words, and if you send us 2,701, we will reject it. That was actually the wording in the letter. And I actually, when I sent it back in, I was like 2,692. And I actually told them what program I used to count words and where I started and where I ended in case they used a different program that changed the words a little. Because I actually do kind of believe at 2702 they were done. But, when you're doing abstracts, so this is, I probably shouldn't say this out loud as, somebody who's been a journal editor. When you're putting it in the abstract box in Editorial Manager and it says 150 words, but your abstract's really 180, I just cut out the methods. Nobody reads the thing in that damn box ever anyway. And I just write what I want in the paper. And you know what? It always goes through and get published that way. Because that stuff, it's not real. It's just like a box.
This session's recorded, right?
Oh, the session's recorded? You could have told me that first.
You are contradicting our current slide. I would say in general, like this example of like give them the methods and like go drastically over their word count is maybe not the best method to follow in general, right? Always try to get to the word counts if you can, and honestly, every single time that we've gone to like seriously wordsmith a paper to cut out hundreds of words because we're over, it's always a better paper after. So like that wordsmithing part, it's a super valuable part. So like try to stick to the word count. Also, like, I don't know, maybe Judd Hollander gets like a special pass somewhere, but you know,
No.
Journals give you a structure for a reason. If you don't care, they don't care, right? And that goes to, right, journals will tell you the methods, this is the structuring, these are the headers, this is like, pay attention. They do change per journal. And, you know, many of the journals know each other. You didn't meet the first tier, you went to the second tier, and they're like, oh, they never even changed from the other journal's format, right? So make sure you pay attention and make it clear to them that you are submitting to them.
And that in terms of formatting of the subsections, you know, the annals is a little strange in our literature. They want limitations ahead of the discussion. Yep. That means you have to redo your references if you went someplace else first and redo that. But if you don't do that, they know you didn't go there first. And some journals get deeply offended by the fact they're the second choice, which is insane because we all go through a couple journals. And the other thing is, when you get rejected, take those reviewers' comments to heart and change all the big items and even some of the little items, because I cannot tell you the number of times I have gotten the same paper sent to me from 2 consecutive journals. It's a decent amount, and I had one paper, I had the same reviewer at 4 different journals, and he was the moderator for the abstract session at SAEM, where I overheard him tell someone, I saw this paper at these 4 journals, I can't believe I'm moderating it now. You know, so make those changes. They also make the paper a lot better. And so take that seriously. You want to just say, I'll just submit it here and be done with it. That doesn't help. There's a decent chance one of the same 3 people are going to get it again.
There is also a session on peer review tomorrow, if you guys want to talk more about that. But so in general, the methods, right, again, structure might change a little per journal, but you've got your overall study design, right? This is a qualitative study, this is a randomized controlled trial, this is a prospective cohort study, right? Whatever you're doing. You name the study design, give them the setting where it's performed and a little bit of detail, right? You're kind of naming the hospital or the health system or wherever of whatever size, urban, rural, wherever you are. Give them an idea of who the participants are, and you want to really include clear inclusion and exclusion criteria for those participants. Give them your methods of data collection, who collected data, was there any specific training needed, how did they get that training, any interventions that were done, the primary outcomes, or all the outcomes, right, the primary and then other outcomes that were measured, and justifications for why you use them. Sometimes it's obvious why you do. You don't always need that justification, but if there are multiple things that could be used, you need to justify why. And then give a clear understanding of your primary data analysis. Any methods questions? We're not going to make you write the methods for your projects here.
But you are going to be up for the results, and the groups that weren't called on last time and didn't volunteer can be voluntold and will be expected to report out the results flow, just so you know.
Okay, the results. And again, this doesn't apply to every study you've got, depending on your study design, but overall, you want to begin broad and then drill down to your study population, right? So generally, people want to know of your population, this is the number approached, these are the ones excluded, and why, and then these are the ones enrolled. And then usually, it doesn't always hold true, but usually your table 1 is your patient population description. And so this is going to include general demographics of the population and any other relevant features to your study. Generally divided into study groups, if you do have different groups, and then comparing any major features of the groups. Did they differ at baseline in any way is always an important comparison to look at. Then you're going to be giving the overall main outcome first. You always want to be given your primary results of your primary outcome first, and then any secondary outcomes. And then you may go into a deeper dive into data that maybe explains findings, so exploratory hypotheses or other things that you may have been looking at in the study.
So we want you to take your groups now, take your project, and design table 2, what your primary outcome will be, maybe what your secondary outcomes will be, and then maybe anticipate a couple exploratory things that you would do afterwards.
Another just important point, though, on the results is the results are just the results. They are the facts without your interpretation. I see it so often that people, like, words like interestingly, surprisingly, like, no, they do not belong in the results ever. That is your interpretation. Keep that for the discussion. This is really just giving us the facts.
They, in fact, don't belong anywhere in the paper because it's supposed to be scientific. So one of the things the reviewers has to trust is that you are an unbiased presenter of the data you got from your unbiased study. And as soon as you start putting in adjectives that make your study seem bigger and better than it is, because most of us aren't winning Nobel Prizes with our current literature, it looks like you are trying to slant your study in one direction or another. So rather than say surprisingly, you could say something like, and I guess we're getting ahead of ourselves a little bit, we would have anticipated that it would have shown this, but we found this, and then talk about is there biologic plausibility or some explanation as to why your finding might make sense. And that's a reasonable approach, but not like, holy cow, look what we got. Okay, so why don't you go back to your groups and try and sketch out the results section, and we'll give you 3 minutes for this.
And so, like, thinking out, right, for table one, like, what would be those main features that should be in there based on your result? Like, right, what are the things we would need to know? You don't need numbers in there and such, but thinking out, like, what would it be that you're presenting in there? Plenty of time. You can give them.
Okay, 30 seconds.
Like purple on Microsoft Word where it has all this.
Okay, I think we're pretty good. So I'm gonna call on groups actually for real that didn't speak before. If you're not ready, just say we're not ready. So you guys up front, the trio up front over here.
I don't know that.
Yeah, let's see.
You guys ready?
You've been volunteered. Just give it your best shot. So what would you put in table number one?
Okay, well,
So what's your study?
So our study is basically looking at the effect of health disparities, specifically socioeconomic status, on pain intensity scores and pain interference scores. So for table one, our description would be basic demographics, gender, ethnicity, age, but also some psychosocial variables. So certain comorbid diagnoses, depression, what were the other things that we were looking at? Highest level of education.
Okay, so
health literacy
so summarizing
scores.
what you're saying, it's basically demographics and clinical characteristics that could tie
Correct, right.
either into baseline characteristics or your outcomes.
Right.
Right?
And how we would divide the groups is we're going to use the area deprivation index as our way of dividing people of high socioeconomic status versus low socioeconomic status.
Stand up, see, just probably easier.
Yeah. So basically, we're going to have group 1 and group 2, and how we're divide them will be based on their area deprivation index score. So people who are 75th percentile and higher will be considered more socioeconomically disadvantaged, so that'll be group 1. Patients who are lower on the scale, 75th percentile or 74th percentile or less, will be group 1, and that's group 2, and they will be considered higher socioeconomic status. And we're going to compare group 1 and group 2 based on the pain. I guess those are, so our main outcome, which is the pain intensity score, and pain interference scores. And both of those scores, we're going to use validated survey tools, the PROMIS tools, which are available on the NIH website.
Okay. So that work for everybody? Right? That's pretty good. And she snuck in the results, which really would be in the methods, that it's using validated tools, which is actually like a really critical thing to do. Okay, Jason, your team. And please stand up so you'll just transmit better.
Yeah, we are looking at sepsis patients with some comorbidities, and our demographic section is with race, age, gender. We have some lab values at the ED arrival, some vital signs, and the Charlton Comorbidity Index. We divide it into 2 groups based on the presence of comorbidity, this case congestive heart failure. And our overall outcomes are mortality in hospital, 30 days, 60 days, and fluid status, yeah.
Okay, so 2 educational points from their presentation, or from both of these presentations. You can structure your whole results in 2 minutes. You could stand up when they're not even fully structured, make it up while you're talking, and get the right stuff out, right? I've seen the looks on the faces when they're standing. You know, it's not really that hard. The whole writer's block is just not taking the time to do it. And when you break it down into little segments, that's pretty easy to do. So we'll move on.
All right, the discussion. Mostly our last part, although we've still got our limitations in this. This didn't come before discussion here. So generally, get in and get out. Less is more for the most part. Don't just have a discussion that like wanders along. Get your main points out. You want to first take the first paragraph of the discussion to clearly state your findings, kind of again. Right, in our population, we found that XYZ factors, like increased risk for sepsis or whatever it may be. Then you want to frame your results in the context of prior knowledge and the unmet need. This section is going to be more depth than the intro on the relevant past studies. Probably you're going to go into a couple key studies, maybe a 1-line description of them and then their primary findings, and want to be kind of comparing, contrasting what you find compared to that, and leading into, right, our study replicated what was found in the prior studies and also added this element, or in fact our findings were very different, which may be due to XYZ reasons, but put them in that context. Assume your reader generally knows the topic. Don't define the disease. And then, yeah, as I had said, how do your findings fit into that context, right? You want to highlight new knowledge here, and then highlight some future directions of where this work will go, especially if you're going there, right? Like make that unmet need that you're going to fill in the next paper too.
Yeah, and I'll add, I'll just do, a lot of my work was risk stratification of acute coronary syndrome patients. So, we found X. Like, okay, we found that, if you get two high sensitivity troponins in 2 hours, you could have a negative predictive value of 99%. That's really clear, right? Then, the rest of it, in my introduction, is a lot of people have chest pain. We over-admit chest pain. We don't really know. There's 8 million studies that have looked at different algorithms, and they can't get to greater than 99% negative predictive value. References 2 through 481. It's not through each one. But then in my discussion, I got to 99% negative predictive value. I might actually, 10 years ago, have said, well, in the CKMB studies, so-and-so did a study of 831 patients, and they had 10 misses, and their negative predictive value was 97. and so did a study and their findings were this, and so did a study and their findings were this, and look, we actually found switching from MB to troponin did better because our sensitivity is higher. It's much more detailed about what the new knowledge is and what the old studies are. The intro is just sort of, this is what we know, and clump the references together. It might be 4 or 5 different things, but it's not Rising previously showed in 431 patients, blah, blah, blah. The discussion is much more that way. What kills me when I read discussions is, and one of my mentors said to me early on, get in and get out, is every tangent you go on means a reviewer might be annoyed by what you're saying. They may disagree with it. And at the end of the day, it is a subjective process. And if people don't like something, your paper may get rejected. So the less things you give them to not like, the less likely you are to get rejected. So my discussions used to be 5 or 6 pages. I now have trouble stretching them out to 2 typewritten pages. They are just like, here's the study, here's the findings, here's the context, here's the conclusion, no stuff around it. I don't need to do that. When Kristin was talking about don't, be an elementary school textbook before and don't say too much, like if you're writing a paper with a med student or resident, they're very likely to paragraph 1 say, asthma is a disease with reactive airways, right? Like we don't need that. We're writing for people that understand what we're doing. So just start as though you're reading it and assume that they're going to get content experts to review it. They're going to have a knowledge base. So you don't need to do that. And then the other thing that I find is don't use the word pilot study ever unless it's truly a pilot study. The fact that you targeted 200 patients and enrolled 10 doesn't make it a pilot study. It just makes it a crappy study. Okay? So, but if you use the word pilot, I'm way less interested, right? Because that means that I need to do a real study with it. And so why do I want to publish a pilot study if I know you're going to do the real study? I'd rather publish that unless it's some landmark thing. So just begin and get it right, on that stuff. And then your conclusion is just what you found. And when you get to talking statistics, and this isn't a statistic lecture, if your p-value is 0.06, it's not statistically significant. Don't say, well, it's almost statistically significant, and it would have been if I had more patients. That just means you understand nothing about statistics. Either enroll more patients and adjust for the interim analysis, or you just didn't find a difference. Then in your limitations, you might say, well, we got close, and maybe a larger study might have shown something different. We might have been underpowered to detect a result. That's a fair limitation, but you can't just ignore the fact you weren't statistically significant and pretend you were, and that's common.
Limitations, in general, you want to make sure that you're sharing your study design limitations. It should be, and again, this goes back to planning the study, they should be limitations that legitimately had to exist, right? Like you just didn't feel like doing it or something, you put the limitations out there and reviewers are going to be like, well, yeah, that's just a bad study, right? So they should be legitimate reasons there were limitations. But you also want to give some thinking to how they might have biased your study, positive or negative, right? We only had a certain population, we only had this. How might this have impacted what we found?
And I'll add to that I tend to be very transparent in my limitations because I tend to try and deal with them up front. And I'm very careful to define how my limitations may have impacted my study. So if I found no difference, but my limitation would have expected me to find a large difference, well, it's still a limitation, but the bias would have been towards finding a large difference. So the fact that I didn't find a large difference when I was biased towards that suggests my finding is real, or the other way around. And so I tried to discuss the extent of the bias. I have in the last 2 years had one paper rejected where one reviewer wrote, they had a great discussion of their limitations, they're accurate, therefore we won't accept the paper. So there is a little bit, and recognizing that this is recorded, the reviewer should have to do a little bit of work. You should be out there discussing the obvious ones, but I've learned that listing 10 of them just to make sure I fill up a big paragraph probably isn't the smartest thing to do that. Listing the major ones probably is. Obviously, I'm an urban hospital. Do I need to write in every study that I do? Well, this is an urban hospital and may not generalize to the community. I don't know. Somebody knows it if we describe it as an urban hospital. So pick and choose, but be honest. So here's just, again, because we're running low on time, I listed my limitations at the beginning of this. On a plane flight, I wrote my limitations. You know, I had time to do that. That's all done. And conclusions we talked about. I know Dimitri's going to be up in, we're supposed to be off now, giving him 10 minutes. We're going to cheat and steal a little of his time since we started late. But the conclusion is just 1 to 2 sentences, and it's just what you conclude. It's not everything else you ever wished you could say in a manuscript.
References. This is like a real pet peeve of mine. Cite the primary references. There's often a fact that's cited. You go to the citation, there was a line in there where they cite something and it came from another paper. Go back to that source and be looking at what they're citing. Half the time I go back, it wasn't actually a citation that even made sense in the first place, so don't continue that down the line. So go to the primary sources when it doesn't, if sometimes citing the review article is appropriate when you're citing reviews, but otherwise shouldn't be review articles. Textbooks and white papers not ideal when they don't have to be, so be careful about what the references you are and use kind of as pure sources as you can, and make sure you format them correctly. That's another thing, back to different journals want different formatting. Format to the journal that you're going to.
Okay, so we're going to skip this part. And so this is actually my favorite letter ever. So I just have some examples so that when you're feeling bad and you're rejected, this will hopefully make you smile. So this is an abstract rejection. For those of you who know Deb Harry, she was president of SAEM, was program committee chair. She was, she's actually now branch chief at the CDC with a really high position. When she was program committee chair, she submitted an abstract, you see, Dear Dr. Howery, and she's the signature on the thing rejecting her own abstract. So, like, that's cool. So these are some early reviews I got. This is actually the first paper I ever wrote. This is a cocaine chest pain paper. I know who wrote this, actually. It says clearly 5.7% of all patients who come to the ED with cocaine chest pain do not have AMI, which is what we found. You're manipulating data to overemphasize the incidence, create cocaine phobia, and a medical legal nightmare. And now they got some spelling typos in there, but this is a wonderful first review, right? That's what you want. This one I particularly love. It's a couple papers later because they point out that I'm obviously wrong because I disagree with myself. And this is heartache. This is when I was at Stony Brook. I worked with Mark Henry on a project, and you can see here that this is a revision. I don't know if the lines pop up. No, they don't. So if you look down to the second paragraph, it says if you decide to review your paper, there's no guarantee it'll be accepted for publication, blah, blah, blah. Getting a revision from JAMA is great. Then we get, I presented your extensively revised manuscript today to the other JAMA editors, along with the comments of 2 of the 3 original reviewers, blah, blah, blah. Last sentence, there remains some concern about the accuracy of information about seatbelt use, but most of the editors agreed that your method of determining this was the best that could ever be done. Then they asked for a revision, then they just sent us a generic rejection letter. Like, that's heartache. Yeah, you know, so I'll warn you, I have had on 3 occasions, 2 of them at JAMA, maybe it's 4 occasions, 2 of them at JAMA, had revisions and then had papers rejected. So a revise and resubmit is not a guarantee acceptance. My last one of those, after publishing, then JAMA changed their form letter, by the way. But, so don't take that you know, too lightly and think you're done. So the bottom line in all of this, it's really about upfront preparation. Have the right question, really tight methods, really tight elevator pitch, your unmet needs, crisp presentation, pick the right journal. If you're writing about geriatrics, don't send it to a pediatric EM journal, right? I mean, that's kind of an obvious example, but you want it where their readership will be interested. If it's really a ER thing that's only for ER, probably the cardiology journals don't care. Probably the New England Journal won't care. If it's really broad, you could go to a general medical journal. And remember, it's not about you. It's about the project. So when you're rejected, you're not rejected. Your project's rejected. You're still a good person. You should still go home and have a glass of wine with your spouse. You know, enjoy your kids. It's not personal. And Jim Adams gave a great lecture on leadership. Was anybody at the Junior Development Forum when Jim gave his talk? He made a great thing about, like, your amygdala responds right away and you want to just start a fight because that's how we're built. And that's the way you all feel every time you get a rejection. So my approach is always, I read it over, I curse at them, I print it out, I throw it on the side. And when I go to do my revisions, a couple days later, after I get over the emotional response, I don't open the paper. I respond to the revisions. I actually write, done, or what my response is going to be. So I respond to every one of their line items. And then I wait a day again. And then I actually type up the whole cover letter, the whole revision letter with how I'm going to respond. And then I open the paper and change the paper by what I'm going to do. And it stops me from reading the paper and being offended that someone wants me to change it. Because I know if I respond to these 25 points, it's probably going to be published. So the emphasis is not how I change the paper. The emphasis is how I answer those 25 points and realize you don't have to do everything, but the reviewer who criticized you, reviewer number 2, isn't getting your response to those things they criticized. They're only going to see if you address them in the paper. So it's important to, if you can't do it, make it a limitation because they'll see that you did that. And so we do Twitter once in a while, so if you have questions, throw it out there on Twitter so the whole world can see the answers to the questions rather than individual emails. And we will stop now and we will, give kudos to Dimitri Papanoglu, who's going to talk about how you could be a vice chair of education or something coming up next. And Lion's Den, for those of you with more research rather than education interest, is at 2:30 as well, which is the Shark Tank pitch for researchers. Thank you for coming. Sorry about the technical glitches up front.